So hello, everyone. Thank you for joining us tonight. Tonight we have the pleasure of having Dr. Jason Cobb. Um, he took the time to be with us tonight to answer some questions. Thank you for being today here, Dr. Jason Cobb. How are you?
I'm good.
All right, that's
Thanks
wonderful.
for having me.
For sure. Just to start us off, can you just tell us a little bit about yourself? What do you do?
Okay. Um, I'm Jason Cobb. I'm from Washington, Georgia, but I've been in Atlanta since 1998. I did undergraduate at Morehouse College, medical school, residency, and fellowship, all at Emory University. So I trained here at Emory from 2002 to 2011, and I've been a faculty member since 2011. Now I'm an associate professor of medicine in the renal medicine division. So I'm a nephrologist. I take care of patients with kidney disease. And I'm a general nephrologist. So I see patients in the hospital, the chronic kidney disease clinic, and outpatient dialysis, including home dialysis. And I'm based out of Emory Midtown. Um, I have a research interest in education, particularly fellowship education. I'm the associate program director for the nephrology fellowship program. And I have an interest in diversity. I'm on the American Society of Nephrology Diversity and Inclusion Committee in the Department of Medicine's here at Emory Diversity, Equity, and Inclusion Committee. And some of my other research includes glomerulonephritis, particular lupus nephritis. I have a lupus nephritis clinic at Emory Midtown. And right now I'm enrolling patients in a FSGS study, focal segmental glomerulosclerosis, particularly looking at African-American patients with APOL1 genetic variants. So that's me.
I remember us talking about this on that research conference where they were talking a little bit about that specific gene variant that causes that disease that you were telling me about.
So as we know, in the United States, minorities progress with chronic kidney disease to the need of needing dialysis or end-stage kidney disease at higher rates compared to white patients. And African Americans have the highest rate, about 3 to 4 times the odds ratio of white patients. And it was always, kind of interesting to see. You got multiple studies with African American patients, same amount of kidney disease, diabetes, or high blood pressure. But a lot of times African Americans progress more than other patients. And now we think we have a cause for a significant amount is APOL1. It's seen particularly in people from West Africa, and people have migrated throughout the centuries with the African diaspora. And people with the G1 or the G2 variant seem to have increased risk of chronic kidney disease, end-stage kidney disease, needing dialysis, FSGS, what I'm interested in. HIV-associated nephropathy has now been associated with APOL1. And possible lupus nephritis, another thing that affects African Americans at higher rates compared to others. So we get to this point in medicine now where it's kind of fascinating that we could be talking about genes and what we call precision medicine, where we don't treat all patients the same, that we can start treating patients depending on which type of genetic variant they may have, which is very exciting.
That's very interesting, that sort of tailored approach to treatment. Now that we can just delve deeper into like understanding the genetic underpinnings of disease.
Well, we're not at that point now. Maybe tailored treatment toward diagnosis, but actually the study that we're doing right now, the VERTEX study, possibly looking at a medication that could look at the things that APOL1 produces. But the main thing of the study is getting as many African-American patients with FSGS and getting them tested for the genetic variants.
Okay.
But hopefully by the time you all are in medicine or getting your PhDs in research, we'll be at that point.
Wonderful, yeah. Just as a second question to follow that up, it's a little bit here. Why did you go into medicine, and are there like any particular experiences that led you to this career?
Okay. So in college, I was actually at Morehouse in the dual degree program where I was supposed to be doing part of my time at Morehouse and finishing up at Georgia Tech. I was a NASA scholar where I did internships each summer at NASA, and they all are engineering type internships.
Right.
I knew by the second summer that wasn't for me. Probably even after the first summer. I needed more people interaction. The science was interesting, but I definitely knew I needed more interaction with people. So I ended up shadowing at the hospital at night after working long days in the internship, and I fell in love, especially the summers in Cape Canaveral at the local hospital in Cape Canaveral, Florida. And I was a patient transporter and also shadowing in the emergency room. And I just knew that that was for me, medicine. Got to medical school, thought I was going to be a pediatrician. Quickly found out after doing my pediatric rotations at Hugh Spalding, which is the children's hospital near Grady, that quite wasn't for me. I knew I wanted to take care of the entire patient, and I was thinking I was going to be a pediatrician and take care of kids, but there's a lot of work with children just to do a physical exam and do a history. And so I definitely went toward the adult side and decided I wanted to do internal medicine. In medical school, I knew I was good when it comes to physiology, pathophysiology, acid-based stuff. So I was thinking about nephrology versus cardiology, because they both deal with a lot of physiology. I came into residency open-minded, but really that first year of residency, internship at Grady, I found HIV-associated nephropathy, and I found it lupus nephritis. HIV and lupus, they affect the heart and they affect the kidneys, but they affect the kidneys at a higher rate. So even now in my practice at Emory, I see in my clinic, probably about a third of my patients, maybe 40% of my patients have lupus, and a significant amount have HIV. So that did it for me intern year that I wanted to do interest in HIV-associated nephropathy and lupus nephritis.
Wonderful. Well, I guess you also answered one of the questions that I also had, which is why did you specifically choose nephrology as like your medical specialty? That makes sense.
Yeah, and definitely do things you're interested in. Another thing too, growing up, my aunt had end-stage renal disease and was on dialysis. A lot of people in my community were on dialysis, but I quite didn't understand the specifics of dialysis at that point. So definitely that also pushed me toward nephrology once I got to medical school.
Wonderful. Another question here. What does a typical day look like for you? Could you walk us through a day in your life, basically?
So that's one reason why I love nephrology. We're one of the specialties where you're not in one place. The average nephrologist is going to be in the hospital a significant amount of time, taking care of patients in the intensive care unit that develop kidney disease. People who already have kidney disease get admitted to the hospital at high rates. So we spend a significant amount of time in the hospital. Then we all do clinic. Most nephrologists will have a clinic which is geared toward chronic kidney disease, such as taking care of patients with diabetes and hypertension who will progress to see chronic kidney disease and possibly needing dialysis. But mine's a little different. I do see those patients too, but I see a high rate of lupus nephritis and HIV in my clinic, and that's one of the great things about being in academics, that you can kind of tailor your clinic to what your research interests are. Then a significant amount of my time are actually in the dialysis units, where people do dialysis 3 days a week, Monday, Wednesday, Friday, or Tuesday, Thursday, and Saturday. Then a significant amount of my patients also do dialysis at home, doing peritoneal dialysis or home hemodialysis. So a typical month for me, I'll do hospital duty for a week, and I only take care of patients in the hospital, in the ICU, or on the general floors in the emergency room, anyone with kidney disease. The other 3 weeks of the month, I switch out. I have clinic days on Monday, Tuesday, and Friday, where I see my patients in my office. Wednesday is my home dialysis day, where patients who do dialysis at home see me on Zoom or come to my home clinic. And on Thursdays, like today, is my big hemodialysis day, where I see my patients in the center who go 3 times a week. So today I've seen about 50 to 55 patients a day who are all on hemodialysis. So I only have second and third shift dialysis. So I got there around noon and I finished around 6:30 and just see patient after patient with hemodialysis today.
Okay, thank you. Yeah, just as a follow up for that, would you say there's an advantage of clinic dialysis over home dialysis?
So outcomes, patients that do it at home have better outcomes. Unfortunately, in the United States, only about 8 or 9% of patients are doing dialysis at home. Emory dialysis, we're proud, we're around 18 or 19%. And personally, about 30 to 35% of my patients are doing it. My personal patients are doing dialysis at home. Better outcomes, less hospitalizations, less mortality, so they live longer. Also, patients who do it at home usually have the tendency to live a more productive life when it comes to things like work. When you do dialysis 3 days a week at a dialysis unit, there could be 3 to 4 hours just on the machine. Then you got to think about transportation and getting ready and being in the waiting room. So the whole process could take 5 to 6 hours out of your day 3 times a week. Then the recovery process. The recovery process with home dialysis is usually not as much. They get dialyzed more often. Patients that are doing it at home. And a lot of my patients that do it at home still work full-time jobs or living professional lives working. I have a patient who's a lawyer and still an active attorney doing dialysis at home. Also, for the health system, economically, dialysis at home costs probably about $30,000 to $35,000 a year. To take care of one patient in the center costs about $60,000 to $70,000 per year right now. So it's a lot cheaper. Plus, patients can usually work more if they do it at home. So it's better in that way also.
So how come it's not more widely available, since it's technically like economically advantageous as well?
It is widely available. Is that patient education? So a lot of patients don't even know they have that option.
Okay.
I also think training, depending on where nephrology residents and fellows train, they might not feel comfortable doing it. We actually have a full curriculum where fellows here spend a lot of time in home dialysis, so they are very comfortable with it. So my goal is that when they graduate, they feel comfortable with it, offering to their patients and setting up home clinics.
I understand.
So I think it's an education piece to it. Then physicians being comfortable with it also could be an issue too.
Great. Well, hopefully all those things, they improve for the best, right? So now that
right.
Yeah. What would you say is the aspect of your job that you enjoy the most?
Definitely my interactions with my patients. I don't think you could beat the interactions that a nephrologist get with their patients, especially a general nephrologist like myself. I see my hemodialysis patients in the center twice a month, and I see my home dialysis patients once a month. I don't think there's another specialty where a doctor see their patients that many times out of the year. I mean, I see my in-center dialysis patients 24 times a year, and my home patients at least 12 times a year. So the continuity of care that I get as a nephrologist, the ER paged me in the middle of the night. They don't even have to give me the backstory on the patient. I can tell them, how long this patient had this and how long they had that without even opening the patient's chart. And also the relationships you get with the patients, seeing the patients that often. I know a lot of people like primary care or family medicine talk about, how they see their patients long-term for, 2 or 3 times a year for the rest of their lives. But we see our patients twice a month or once a month for the rest of their lives. So it's a pretty close relationship that we develop.
Yeah, that's impressive.
Another thing about my job I really like is teaching. And that's another reason I love to be here at Emory and academics, being able to teach the fellows. So all of my inpatient time while I'm in the hospital, I always have a residence of fellows on my team rounded with me. And at the dialysis unit, about 50% of my time, I have trainees with me shadowing.
Well, that's great. You know, it seems like you really get time to spend with the same patient throughout the whole year, build these long-term relationships like that.
And that's a fascinating thing about nephrology that I don't think we get out the word enough about that, about the continuity of care part. Because unfortunately, I think a lot of times with our field, there's a lot of focus on the research side of nephrology and not enough exposure, especially in medical school, about the clinical side. So hopefully we get time to have more pre-med students and medical students with us in the hospital and the clinics and at the dialysis unit. And I think they'll get people more interested in nephrology. Unfortunately, we actually one of the fields with the lowest amount of attention or people applying to the field right now. In the United States right now, we average less than 100 American medical graduates each year. We depend a lot on international medical graduates to fill nephrology slots.
Got you. So besides dialysis patients, is there a different kidney pathology where you get to build this long-term relationship as well?
Right. So even my patients I see in my clinic who are not on dialysis with lupus nephritis or HIV-associated nephropathy or CKD from diabetes or high blood pressure, my average patient, even in clinic, I probably see every 3 to 4 months. So we develop a close relationship. And patients with, there are 5 stages of chronic kidney disease. And when we get to stage 4, stage 5, I probably see those patients every 1 to 2 months. So I even see them very closely also.
Okay. Well, thank you.
And also in the hospital. I do hospital service a lot.
Right.
And sometimes we get frequent flyers. So we see some of our patients who come to the hospital quite often now.
Well, thank you for that. So another one, what strategies would you say you follow to achieve a nice balance between work and life?
Take a lot of vacations, but the pandemic has really gotten in the way of my vacation time. But also between family, friends, making sure I find time, do the things that are important. Like, you know, I had to work some holidays, but we're a group and we all cover each other for certain holidays. But I make sure pretty much the big holidays I'm spending with family and friends, taking time off. Doctors are notorious for getting a certain amount of time allotted for vacation, but not using that time. I don't use all my hours either, but I definitely made an effort compared to when I first got hired in 2011. I mean, some years I might have used it less than 50% of my time. I'm definitely closer to using 80 or 90% of my time now. So I've learned over the years. Some strategies also, even at work, we made it now that we cover each other in the hospital. We changed the way that we do call. I actually think I had some influence on the way we changed things. So now we cover each other more, so you don't have to be on call yourself for your own patients so often. So they give you more free times in the evenings also. Even hospital duty. We used to do hospital duty 2 weeks, now we just do it 1 week a month. So that definitely gives you more time. Yeah, you know, hospital duty 2 weeks out of a month only give you 2 weeks to do non-work related stuff. So definitely find times for things that are important. Take time off, vacation time, but also once you get to working too, try to find ways to maximize free time if possible.
I understand.
Medicine has changed. We're not the way that, you know, the doctor carried the pager 24/7 and worked solo. Pretty much everyone now working as big part of systems or working as big groups. Solo practitioners really really going away right now. You're not seeing it the way you used to.
So it's a lot of teamwork as well.
Yes.
Okay.
And also make sure when you sign up that you a team that fits. Unfortunately, I do see a lot of our younger physicians get into groups that are not a great fit for them, and they end up changing practices. But for me, I work at Emory, and we're a large kidney department, actually one of the biggest kidney divisions in the whole country. But they have us kind of assigned to pods. Like you have your Midtown group, your Emory Clifton group, your VA group, your Grady group. So I'm more the Midtown group, and we've been a great match for each other.
That's great that you found your niche there. Another question, what is something you wish you would have known as a pre-medical student?
So I wasn't 100% sure I was going to academia at the very beginning. But I fell in love with teaching. I fell in love with, certain specific groups within nephrology. I did not take any time off. I did not take a gap year. I went straight through from college to med school to residency to fellowship. I wish I had did like a master's in clinical research or MPH. I think that would have really helped my research career even more. Like right now, I know I'm great at developing relationships with patients and getting patients into research studies. But when it comes to the whole clinical trial design and running a study from the very beginning, I don't have those skills. I wish I would have obtained those skills getting a master's in clinical research or MPH that dealt with clinical research.
Makes sense.
I love what I do, and I'm happy with my career, but at this point too, I don't see myself going back to school to do a year or 2 year master.
I get it. Yeah, it's a lot. You've been through many years of school. How many years of school was that?
Okay, so yeah, 4 years of college, 4 years of med school, 3 years of internal medicine residency. So you have to do internal medicine before you do medicine, so especially like nephrology, cardiology, or infectious disease. Then 2 years of nephrology fellowship.
Okay. Yeah, no, that's definitely a lot. 8 + 5.
13 years, yeah, 13 years total.
Yeah.
But if I had known, maybe I would have did a year or 2 year master's and
to gain the skills that you told me.
But at that point, though, I think, but then my career would have been different. I probably would have been doing more research and doing very little clinical service or seeing patients. So I'm actually glad I'm doing the other way around. Usually I'm 80 to 90% funded for clinical work, seeing patients, and usually about 10 to 20% funded for research studies.
So do you like the current ratio of clinic to research, or would you rather have it a different way?
Well, if I had did the master's, I think it would have been the opposite. But the way I have it right now, I'm actually glad. I love doing the clinical work and teaching.
Okay, wonderful. Then as a final question that I have here, what is a challenge that you say you faced during your career, and then what lesson did you take from that? Could be any challenge that you choose to tell us.
So I think there are some challenges sometimes when it comes to in the academic ladder. You're the younger person in the group or in the division. There are a lot of activities that you are assigned that don't always line up to your career trajectory, which is promotion. You're academics, you want to move from instructor to assistant professor, associate professor to professor. So you have to learn to say no to certain things that don't fit in that trajectory, because there are a lot of committees and lectures and activities you can get assigned to, but they're really not going to add to your portfolio when it comes to your academic career. So you got to learn to say no. Find the right mentor. And I ended up finding a great mentor who definitely helped me with that. But I actually didn't meet him until I was a fellow, and we became really close when I was a junior faculty member. That's Dr. Bill McClellan, who has now deceased, but he was one of our nephrologists based out of Grady. And so, start saying yes to things that focus on your career trajectory and go get you the things that you need. Because even now for y'all, trying to get to medical school, trying to get to the PhD program, you got to learn which things are going to make your CV look better and which things are not going to add to your CV. So you got to be careful about, which activities you end up taking on. And even with me, you were like, wow, you're still worrying about your CV 25 years later, but in academia, you got to, if you go into the academia route. So, and that person even, really showed me that, oh, you get excited when you talk about lupus in the kidneys. You get excited when you talk about HIV in the kidneys. You get excited when you talk about health disparities and diversity issues and in nephrology. So he really, really focused. So probably about the second or third year of my career, I really started focusing on developing my lupus nephritis clinic, getting consults for patients with HIV-associated kidney disease, and focusing on health disparities and diversity and inclusion. All that stuff has led to things that really helped my CV and helped me along my academic career.
Thank you for that. And then just like to close us off, could you tell us maybe about an interesting specific case you've seen that maybe, I don't know, reflects what you do as a nephrologist?
Interesting case. They all are interesting. That's why I love nephrology. But we'll have one case though. She's one of my patients I've been following for a long time. So I'm not going to talk about her today, because I saw her today, but I'm going to talk about her for the last 8 years. Mm-hmm. So she was seen by rheumatology at Grady. She has lupus, and at that point, she was probably only 25 or 26 years old, and was starting to affect her kidneys. She was referred to my lupus nephritis clinic at Midtown, and started treating her with oral medications, and she did really well with her lupus nephritis. But when you young like that, you want to develop families, you want to have kids. And when she got into remission, we talked about the possibility of talking about planning a family, but she ended up having a lupus flare, and the oral medications weren't working. And we ended up having to start her on IV medications like Cytoxan. And that's pretty much chemotherapy, the lower dose. We use a lot of drugs like that are used in chemo in kidney patients, but at lower doses. And I talked about not getting pregnant and, you got to get over this flare. She's like, so you do this for 6 months. She's like halfway through, and she ended up becoming pregnant. And we ended up having to make, difficult talks about, do you terminate the pregnancy? Do you terminate the pregnancy and continue the IV therapy for your kidneys? Because a lot of times with treatment, patients with lupus nephritis will definitely respond. Or do we stop treatment, see what happens, and you continue with your pregnancy? She decided to continue with her pregnancy. Her kidneys end up failing. She ended up having to start dialysis. She followed me to the outpatient dialysis unit, so she continued to be my patient. And then at some point, now her, she showed me pictures of her kids. She put them on FaceTime on the phone. He's actually doing Little League or Pee Wee football and stuff now. But now with the pandemic, he's like kindergarten and first grade now. She needed more time. Like I said, dialysis in the center 3 times a week. That's a lot of hours away from home. She needed to be at home more. So we decided to do peritoneal dialysis. So now she's doing dialysis at home so she can help him with his schoolwork and help him with Zoom and get him through his school day. She actually just got admitted to the hospital. I was on hospital service last weekend. for some abdominal pain. We ruled out infection. She didn't have infection in her abdomen, and we ended up sending her home. But that's just a good example of somebody with a chronic kidney disease that I've been following for such a long term and been through all the complications with this patient. And the big thing now, and we both were trying to lose weight during the pandemic, you can't get a kidney transplant unless your BMI is less than 35. So we spent this time working. Her BMI was in the 40s, and now her BMI is less than 30, right at 35. So we refer her for kidney transplant around November or December. So hopefully I'll see her through the process of getting a kidney transplant too.
Well, that's incredible, because it's like such a long timeline of events, and you just happen to know them very well, you know?
And that's a special thing about nephrology. All nephrologists will say the same thing, that the continuity of care, especially the ones that do general nephrology, where they take care of patients in the outpatient setting, they love the continuity of care.
Well, Dr. Cobb, thank you so much for your time. It was wonderful talking to you, and thank you for sharing all of this experience with me and with the rest of the Emory community as well.
Hey, thank you. Thank you for the opportunity. And
Sure.
think about nephrology, everyone. At least think about us.
Bye, guys.